Should I check? No one's coming. Just check. Are you on?
Today we're going to talk about expanding your falsetto voice.
बातें रखेंगे आप इधर है ना Hello.
Hello. I'm not supposed to be doing anything here except listening to the whole talk. It's the same way as you are expected to do. But Dr. Hetal was to introduce Dr. Nupur here. I will still leave that for her. I'm just going to mention only one thing, that like you people now, Dr. Nupur sat here once. And of course, Dr.Manu Kothari and myself, we had the fortune to be on this side at that time. And we had great pleasure. So rest of the things, sometimes there's, her talk itself will be what she is, and of course Dr. Hetal will do the rest of the things. Please, all those of you at the end of the whole talk will realize what a human gift which all of us, Upawala in the air, it's a rare, and how we should treasure. Thank you.
I think you go and start because they have been okay. Hi, good afternoon. It's really, can you hear me at the back? Yes? Okay. It's indeed a huge pleasure for me to be here with all of you because, as Madam very rightly said, my alma mater is KM. I used to be sitting on those back benches, exactly where the red t-shirt is sitting right now. And it's been a long journey and it's been a wonderful journey. I had Loka ma'am and I had Manu Kothari sir as my teachers, and the atmosphere was so vibrant and energetic in the Department of Anatomy. And whenever I relive those moments, it's just amazing. And you carry what you learn with your teachers the rest of your life. So that cannot be taken away from you. So thank you so much, Loka ma'am and Manu Kothari sir and the entire team for being the most prestigious, I would say, anatomy department. I've just come up from the MLT where a talk was taken on KM being a brand equity. So it was very interesting, and all of you belong to that brand equity. So congratulations to all of you. So today's talk is being delivered in the Dr.Manu Kothari Humanities Chair, and the topic of my talk is Voice Matters, and I've divided this talk really into two divisions. But before I started, I would like to acknowledge all my patients, and you're going to see a lot of my patients in my talk. You'll actually see their faces and hear their voices. And sometimes it may make you laugh, etc. But at the end of it, we have to remember they are patients and we have to be humane about it. And the reason why I show the faces and make you hear the voices so that you can understand how the voice changes the personality of an individual and what it means to an individual and how we can help them. And I do have my permission from all my patients to share this with you. I of course want to acknowledge all my teachers. KM, which is my undergrad and postgrad alma mater. And I especially would like to thank the existence of the Clinical Research Lab, the Dean of KM, Dr. Kirtane and Dr. Goya, the head of department, because we've been running phonosurgery workshops almost every year in Bombay Hospital in association with KM Hospital, and we do the cavernous cadaver dissection in KM. And really, that forms a very huge basis of training. And these are ENT surgeons who may be practicing since 5 years or 25 years, who come here and still do cadaver dissection. So what that tells you is that the most important thing really is anatomy, anatomy, anatomy. So we are coming back after 25 years and still training. You are right now in the Department of Anatomy and you have all the facilities. So respect them, and that'll take you a long way. You know, I was in KM Hospital in.
Sorry for correcting.
Yeah.
They are all doing ENT term.
Oh, you're all in ENT. But you still have the opportunity to go to the CRM. Fine, great. So I was in KM in 1985, 25 years back. And I did spend a lot of my time, unfortunately, playing basketball. But flash forward to 2016, and these are photos of KM, the anatomy department, and we're doing the phonosurgery workshop training programs where we do framework surgeries, we do laser surgery training, and then because of the experience you garner, you are able to go outside of India, like this is in Kenya, and I'm doing a training program in Kenya, but unfortunately in other places it's not as feasible and possible to get human cadavers ready to dissect on. We're operating very often on pig larynxes and goat larynxes. So to have the opportunity to train on human cadavers is especially wonderful, and we really have to respect the cadaver and we have to respect the opportunity we have been given. Professor Manu Kothari, I do want to talk about for 2-3 minutes. Sir, obviously you're probably did you all have an opportunity to interact with sir? The students? No. Okay. So really, of course, you can Google a lot about him. Maybe if you Google, you can hear him singing a song or taking a talk, etc. But sir was the most outstanding personality. I cannot describe to you what he was. He would stand here, take a talk, and he would mesmerize the 100, 200 people because he would have amazing knowledge. He would have an amazing knowledge not only of anatomy but of shlokas. He would have the most amazing humor, so he would have you in splits, and he was so humble. He was humility personified, and the most remarkable kind of a person. And when you were doing your anatomy term, you could walk into the Department of Anatomy, where ma'am would be the head of department and sir was the head of department. You could walk in and having lunch and go with any of your questions. And with that kind of, when you see that kind of a human being, sometimes you don't have the maturity to appreciate what it is at that time, and then later on in your life, you appreciate what the individual really was. So it is a huge honor to be taking his talk, and I think if you become 1% of the kind of human being he was, it would be amazing. And we would probably not have so many of the doctor-patient fracas which keep taking place in society, because when a patient comes to you, I think the most important thing is to start right. If your first interaction with your patient is correct, because right now you're not clinical, but when you're talking clinically, you're taking the history, a patient has come with relatives to you, and your first meeting with a patient starts right, and you have an empathy. You don't have to be overly empathetic, but you have to show some empathy to the patient, because no patient wants to come out of their own willingness. They're coming because they're not well. So if you start right, then even if things go wrong in surgery, there's a complication, there's a death, everything does still fall into place as long as you start right and you are always in communication with the patient. And before I start the second part of my talk, I just want to share one incident with you. I was in, after my safety training in KM, I did my ENT, and then I was a lecturer and associate professor for about 11 years. First in KM, then in Sion Hospital, and then I joined Bombay Hospital. And within 6 months of joining Bombay Hospital, I had a surgery where I'm primarily doing voice work and airway work, and I had this patient come to me, elderly, about 80-year-old patient with his relatives. I had never seen them, met them before, and he had a growth on his vocal folds, and I said, you need surgery. He said, okay. They were waiting for surgery the next day. I got my anesthesia fitness. And this is within 6 months of joining the hospital, so I was not so comfortable or, so accustomed to the hospital. Now, we did the surgery, it went off brilliantly. Unfortunately, it was a malignancy, a cancer of the larynx, but we operated well, margins, clearance, everything wonderful. But the patient had a cardiac arrest during the surgery or just towards the end of it because of maybe the anesthesia the body could not take it. He had to be shifted directly into the ICU. Following which, within 1 day, he passed away. Okay. The reason of telling you this story is this is now someone, very often you have patients who you built a rapport with for 3 months, for 4 months. This was a patient I had no rapport with. I didn't know the family members. From their perspective, they've got their father or their grandfather to me, and the patient is no more. The patient passed away the night. I went to the hospital, I spoke to the relatives. And well, to cut a long story short, I explained exactly at every stage what was happening. I was there in the ICU, I went back, I came back. And as I feel, if you're upfront with a patient, if you tell them exactly what is going on, and if your well-being is made apparent to the patient, they understand. The other side is not the enemy either. So I think whatever issues happen, maybe once 1% or less than 1% would happen anyway, but a lot of them would not happen if you just start right. So you may have a very busy OPD and you may be very stressed out, but if you just start right, I think a lot of things fall into place. So I'm going to now actually start with my talk, which is your voice matters. What you say matters, how you say it matters, your tone matters, your body language matters. And you can't rewind what you say or what you do, so be careful about it with patience. I am a laryngologist. So laryngologist is someone who deals only with problems of the larynx, so that may be voice, airway and swallowing primarily. And we do a lot of phonosurgeries. And do you know what phonosurgery is? Phonosurgery is not to phone a friend. Phonosurgery is a surgery which is performed either to restore your voice or to alter your voice. It could be either one of the two, right? You can do the surgery from the neck, which is external surgery, or you can do endoscopic surgery from, we've got a automatic opening the mouth. So you can do it endoscopically through the mouth, right? Now, what is voice? Voice is not what you probably think it is. Voice is just a bzzz, a buzzing sound which is created by the vibration of vocal folds which are present in our larynx, within our thyroid cartilage. That buzzing sound is known as voice, also known as phonation. What is speech on the other hand? Speech is a result of a spoken word. So when I say hello to you, that is a spoken word. So that is not the same thing as voice, because you have the buzzing sound being created by the phonating system, which then gets magnified by the resonators in the pharynx. So it becomes louder and it becomes characteristic. That's why Amitabh Bachchan's buzzing is different from Hrithik Roshan's buzzing. There is a character which is different because there is a different anatomical resonance. And then finally you have the articulators, the lip, the tongue, the mandible, which make the word, which articulate. So all of these together give you speech, which is the spoken word. So what you're going to see right now, this is what is known as stroboscopy. Okay, this is the vibration of the vocal folds. Pointer left. What you see, the two white structures are your vocal folds, and you're seeing a ripple-like action. This is a vibration which is taking place. How many times in a second can you guess for me? 20 times, 100 times, 400 times. What do you think? Loudly? How many times? 174. Oh. Well, that's KM for you. 174 times a second. Absolutely correct. That is the frequency of the voice. So what we wanted to see in this stroboscopy is that are both the vocal folds vibrating equally? Is it symmetrical? Are they meeting in the midline? Is that rippling action going all the way laterally? Or is there a gap, or is there an area which is not vibrating? So this stroboscopy is now the gold standard. Any patient with a voice problem, it's such a simple test. You just put like an endoscope, like a pen in the mouth, and ask the patient to say E. There's a camera attached to the endoscope and you get this kind of picture. So it's very different from 20 years back. You will pick up small malignancies even. This is something different which is showing you the same thing even better. It's called high-speed imaging, where the photos are being taken, you know how many times in a second? 6,000 times in a second. And then they're being put together, and here you're seeing that vibration in slow motion. So for 6,000 photos in a second, your heart rate is going to be huge. So right now it's not practical to do this in every patient, so we do stroboscopy. Okay. And like I told you, for speech, you can appreciate that in this patient who has been put in an MRI machine, okay? And he's singing a song, a writing a song. What are you seeing over here? So you have the tongue over here, the big bulky mass over there. That is the tongue, correct? Right. So you see that the tongue is shaping itself in such a way that it will hit the posterior pharyngeal wall, or it will hit the soft palate, or the soft palate will hit the posterior pharyngeal wall. So you have different kinds of resonance being created, what I discussed with you. So you have nasopharyngeal resonance being created here. When the soft palate hits the posterior pharyngeal wall. You can have oropharyngeal resonance where the tongue will hit the posterior pharyngeal wall, and when the tongue goes and meets the palate, you will have the oral cavity resonance. So this is the resonance and the articulation, which you can't see in stroboscopy. So this is just to give you an idea of how a patient makes different sounds. Okay? So you've understood now that our powerhouse is the lung. All the air is coming from the lungs. From these lungs, the vocal folds are being set into vibration. You have the buzz sound. Everyone has this characteristic buzz sound because of the resonance in the pharynx. And finally, the articulators are saying, hello, how do you do? The spoken word is coming into play. Now, what I want to talk about today is things which go wrong with the vocal fold level and how we can correct it. Or if nothing is wrong but patient wants a change, then we can still do that change. So let's see what I mean by that. We know what the main muscles of bringing the vocal folds together are what are known as the adductors of the vocal fold. What are the adductors? You have the thyroarachnoid muscle. The most medial part of the thyroarachnoid muscle is known as the vocalist muscle. Okay? This whole thing is the thyroarachnoid. When it contracts, the vocal fold will shorten. When the vocal fold shortens, the vibration becomes actually more and the pitch of the voice will go down because the tension is becoming less. You also have the interarachnoid muscles and you also have the lateral cricoarychoid muscles. So it's important for the vocal folds to come together, only then they are set in vibration and we will phone it. Which is the abductor of the vocal fold? Posterior cricoarychoid. There is only one abductor. When you abduct vocal folds, you are not talking, you are breathing. Okay. Then there is one more muscle I have not mentioned, which is also intrinsic muscle of the larynx, which is that? Which is a muscle I have not mentioned. There is the cricothyroid muscle. This is a very interesting muscle because it causes the vocal folds to get stretched, like a guitar getting stretched. So the pitch of the voice will increase. So this is a tensor of the vocal fold. It also adducts the vocal folds to some extent. So the cartilage is going to tilt, thyroid cartilage tilts anteriorly and moves upward and the vocal folds will stretch. So just like in a guitar string, you can pull the string tight and make the pitch higher, or you can make the string loose and the pitch of the sound can go lower. You can play around with the vocal folds. What is the pitch of the males? Normal fundamental frequency, which is written as F0, is about 100 to 130. For females, it's about 200 to 230. Now when you're talking in your modal register, what we call, okay, this is your modal register. So when you're singing, you're not singing in a dull modal register. So you'll either go very low, which is known as vocal fry, or you'll go higher, which is falsetto. And there are some singers who go so high that we call it a whistle register. It's as high as that. What is falsetto mode? The thyroarachnoid muscle which we saw, when it's contracting, the muscle is becoming shorter. So the thyroarachnoid muscle is totally relaxed, but the cricothyroid is contracted in this falsetto mode. So really it is only the vocal ligament which is vibrating. And this lady will show you how we can go into a falsetto mode.
Instructor and professional singer at Rock Studios. And today we're going to talk about expanding your falsetto voice. The first thing is to have the right posture. It's important to think of your body strong and tall and imagine a string coming from the top of your head and pulling you upward. And that helps to increase your falsetto voice and expand. And the next thing is to stretch the muscle. Some people do that by doing scales on a piano or singing. For example, singing ah, ah la 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 la. notes going higher and higher and stretching the muscle. La 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 la.
So that's the falsetto mode. Then you have something known as yodeling. What is yodeling? When you go suddenly from falsetto to modal, falsetto to modal, falsetto to modal. So who does that so well? Yes, this is known as yodeling, okay? That's yodeling. Now yodeling is something which typically is easier to do in inspiration. This girl over here manages to do it in inspiration and expiration. Just hear her, she's quite amazing.
Intake.
I take her to where she's actually sitting. She's doing it in inspiration and so that's very difficult. And then as I told you, there's one more register which is known as the whistle register. And here in the whistle register, you're going to 1000 hertz. And this is surely going to damage your vocal folds. We haven't clearly understood what happens to the vocal folds when it's vibrating 1000 times in a second. But typically the singers who do it slowly, their voice surely gets damaged. Mariah Carey is one of them. And I think her voice is going to be ruined very soon. Into vibration when you talk normally, but sometimes the false vocal folds also vibrate, and that's not normal, and I'll show you what that looks like. And that may happen because you've removed part of the true vocal fold for malignancy. So you see over here, it's the false vocal folds. See, these are the false vocal folds, and they are totally vibrating now. They're not supposed to. The true vocal folds, so this is known as ventricular phonation. So these are the ventricular bands, or plica ventricularis. And there are some people who purposely will phonate them in a type of singing which is known as a Tibetan chant or a Tibetan throat singing. Just to make you hear what it sounds like. This is what it sounds like. He's using his false vocal folds to sing. So it's a different way of doing it, right? So we know how to now we know how to change and play around with pitch. How do we change? How do we increase the pitch? If you increase the tension, what's happening to the pitch? It's going to increase, okay? If you are going to increase your subglottic pressure, pitch is going to increase, okay? If you are going to increase resonance, pitch is going to increase. But if you are going to increase the length, the pitch is going to decrease. That means if you are going to decrease length, pitch is going to increase, okay? So remember that. And if you are going to increase the mass, the pitch is going to decrease. That means a thin vocal fold will have higher pitch than a thick vocal fold. Okay, so now we know the science behind it, so we can use it to change the pitch of the voice in patients. What do we do? What is the first surgery I'm discussing with you? It's cricothyroid approximation. We saw the cricothyroid muscle, we know when it contracts that the vocal fold gets stretched. So supposing you permanently keep this muscle contracted, permanently. You take stitches and you suture the cricoid up to the thyroid with 4 sutures so that the cricothyroid is permanently contracted. Then the vocal folds are permanently stretched, so pitch of the voice is high. Why would you want to do that? What is the nerve which supplies the cricothyroid muscle? Superior laryngeal. Which branch? External. So supposing there is a paralysis bilateral, that would be an indication for surgery. Okay, let's say everything is fine, but you still want to do this surgery of getting the cricoid up to the thyroid because a patient comes to you who is a male and has done a gender reassignment surgery and become a female. And now the voice is still masculine. So the patient needs a change in voice. So this is a patient before surgery who's had a gender reassignment, dental work done.
4, 5, 6, 7.
So it's a typical masculine voice which we hear. So we do a cricothyroid approximation and this is what the voice sounds like now.
1, 2, 3, 4, 5,
This is unusually high pitched, but with time, in 2-3 months, the pitch will drop a little. There is a dramatic change in the voice that has taken place. Now it matches the person, the individual. There is another way to change it. What did I tell you? If we shorten the length of the vibrating vocal fold. So here you have normal vocal folds, correct? Absolutely normal, and you feel, I felt horrific doing the surgery at late, but I use a laser, make this raw and stitch it up. And so the vibrating vocal fold length is now 50% decreased. So therefore the pitch will go up.
1, 2, 3, 4, 5, 6, 7.
After surgery. Sitting.
Say 1 to 10 a little louder, please.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Are you making any effort when you say
No, I'm
these
not
words?
making any effort at all. I'm talking normally.
And how many days after surgery is this?
This is after 10 days after surgery.
So now,
Say.
we don't do the surgery in everyone because we teach them voice modulation. I can talk like that if I want. You can talk like that if you want. But it is exhausting. At the end of the day, you are exhausted. Secondly, now this is a beauty parlor. She works in a beauty parlor. If she suddenly coughs, the cough comes masculine. She says, my clients look at me very strangely. So these are not things you think of, but there is a reason why they are doing the surgery. And it is a metamorphosis in their personality. Because it's a male who's become a female, but till the voice matches what they are, they don't feel confident and adequate in society. So you do this surgery, and I literally see them, they come into the hospital, get admitted, and they go out something like a butterfly, totally different, because they feel so complete with their voice, what they want it to be. Now there's a different surgery we can do to decrease the pitch, okay, which is known as a relaxation laryngoplasty. So we're doing the opposite thing, where you're making the vocal folds, instead of pulling them, you're going to relax them. And why would you want to bring someone's pitch down? Let's say the opposite situation. You have a man and he has a feminine voice. So that's such a peculiar situation. This is known as pubophonia. 99% of the pubophonia patients will improve by just voice modulation. But there are some who won't and they want their voice changed. So we do a surgery, very simple surgery, where you expose a thyroid cartilage and you just make an incision from superior to inferior on either side, about 4 millimeters from the midline. Because the vocal folds are attached to this anterior commissure strut. So this cartilage of 8 millimeters, and we just push it in. When you push it in, the vocal folds are attached to it, so the vocal folds will relax. So this is known as a relaxation laryngoplasty. All these surgeries are done under local anesthesia. You can hear the voice of the patient, and you can on table decide how you want the pitch to decrease or not decrease. So this is a boy or a man before surgery. कम आता है कि ऊंचे सुर का उससे ज़्यादा आइडियल नहीं आता है आवाज़ भारी कर. So he's saying his voice is high pitched. After surgery, this is what he sounds like. मेरा आवाज़ एकदम चुप पतला था. अभी मेरा ऑपरेशन करने के बाद बहुत अच्छा हो गया है. मेरा आवाज़ He actually said, madam, those बोलता है danger आवाज़ हो गया है. Those were his words. So you have to tell them, they have to be mentally prepared. The voice is going to really dramatically change because a lot of the pubophonics are attached to the apron strings of their mum. You know, so they're little protected individuals. So they have to be, the family has to be ready for the surgery which you're going to do. This was a gentleman from Afghanistan who had 5 brothers, all with pubophonia, all improved with speech therapy. He did. So he did online search and he landed up with me and he said, I need to do the surgery.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
This was his voice. And then we did the same surgery, relaxation laryngoplasty. So what I'm going to show you is on table itself, you're hearing the voice of the patient. Here, this is his voice immediately after surgery.
1, 2, 3, 4, 5, 6, 7, 8,
Dramatic
9,
change in the voice. Okay, so patient is happy and this stays permanently. It doesn't change. I told you the cricothyroid approximation, the pitch which goes high pitch may slowly come down a bit. This one doesn't. Okay? So this is a very successful surgery. So what is happening really in this pubophonia? We have laryngeal elevators, we have laryngeal depressors. If your laryngeal elevators are in overdrive, patient has got pubophonia. So what you're actually supposed to do is send the patient to a speech therapist and have them just bring the larynx down. So now this is a boy who came to my clinic. This is what his voice sounds like. I want you to see how the Adam's apple is bobbing up every time he talks. Okay, what do? I tell him, put your finger there. Don't let your Adam's apple bob up every time you talk. Make him sit in front of a mirror. Immediate, huh? He's right there. He's done it himself. Pitch has gone down. He has to be made sensitized to hear his voice and how it is affecting what he is doing in his neck. That's what the speech therapists work on, and so it's very successful to achieve this. We don't do surgery in pubophonics most of the time. You have the opposite situation which can happen where the laryngeal depressors are in overdrive. Do you know who these people are? Tell me. Humphrey Bogart, and that's his wife actually, but an actress. And he's going to do something. Lauren Bacall, okay? They were married actually, and you know what they sounded like, in case you don't know what they sounded like? Hear the sound of a voice which goes very low pitch, okay?
Hello.
Well,
I'm late. I'm sorry.
how are you today?
Better than last night.
I can agree on that.
Very low pitch.
Hold on that.
Have you seen the movie Casablanca? If you haven't, go on Netflix and see it today. It's a beautiful movie. So this syndrome, this low pitch voice, is actually called the Bogart-Bacall syndrome. There's a syndrome named after the husband and wife. When we go in a very low pitch by bringing our Adam's apple down. Now here, this boy talking, and see what's happening to his Adam's apple. Every time going down, okay? So this is the Bogart-Bacall, and again you can do speech therapy for this situation. This breathy voice, 1, 2, 3, 4, 5, is a very common problem we face because of unilateral vocal fold paralysis. So one vocal fold is not moving, the other one is, but there's a huge gap, so a lot of air leak is taking place. So this is a typical kind of voice that happens in individuals.
2, 3,
It's making an effort to talk, but there's so much air leak taking place.
7.
Why do people develop a unilateral vocal fold paralysis? What are the causes? Viral is a very common cause. Thyroid surgery, unfortunately, still is a very important cause. Any kind of surgery, menisophagus, sometimes even cardiovascular surgeries, and one vocal fold can get paralyzed. So what happens when you do a CT is you see this huge gap. You know, between the vocal folds, you see a huge gap because this is the paralyzed vocal fold. So how do we help these individuals? We want to push the vocal folds so that there is no gap, because we unfortunately don't have a surgery to make the motion of the vocal folds come back as yet. But nerve regeneration surgeries are being worked on, of course. So we put an implant to push the vocal fold to improve the patient's voice. So this is what the vocal folds are doing before surgery. See that there is a huge gap between the vocal folds, okay? And we want this gap to go away, so we put a small implant made of Celastic or Teflon after making a window in the thyroid cartilage, and just push the vocal folds, and then the gap will go away and there will be no air leak. Can you see here now there's no gap? So we do this under local anesthesia so that we can talk to the patient when we're doing the surgery. So we make a window in the thyroid cartilage, as you see over here. This is the left thyroid cartilage. We put a instrument to push the vocal fold and decide how much do we need to push for the voice to be the best. 2 mm, 5 mm, 8 mm, and that, according to that, we make the size of the implant. So here you have, over here, this is the instrument which we use, put it in the window. I'm going to show you a small clip where we're actually doing this under local anesthesia.
5, 6,
Did you see how the voice came
7,
up?
8, 9,
voice went down again. So we know that is working, and according to that size, and we make the implant. This is another patient.
2, 3, 4, 5,
Now I'm going to.
6, 7, 8. I ठीक है now.
He's telling me. But this is really, it happens when you are. You say, ये ठीक नहीं है, madam, ये ठीक है अभी. So you make an implant of that size. So then you sit in 10-15 minutes, you carve your implant out and you put it into place. So it's a very gratifying surgery because the patient is on table improving. We have a very peculiar, very uncommon problem known as spasmodic dysphonia. And these patients were for the longest time thought to be psychological, psychiatric cases. When they have a voice which is like this, it's like your voice is totally strangled. And it's known as adductor spasmodic dysphonia. It's not a psychological problem. There's a misfiring happening from the basal ganglia, which is happening too quickly. So the adductor group of muscles are getting adducted. Before they can relax, they're again getting adducted and again. So the voice is like strangled. So in those patients, you want to relax the vocal folds. You can do that in two ways. One is you can make, during framework surgery, you can do what is known as expansion. Just make a cut, a linear cut, and separate the two thyroid alae by putting implants. So you're creating a permanent gap. What the earlier lady had was a gap. So you make a small gap and the vocal folds can't slam against each other. Actually the gold standard is botulinum toxin, but I'll show you if you do the surgery, this is you put an implant in. If you do the injection, this is how the patient sounds. Spasmodic dysphonia.
I am having some voice problem. For almost 1 year, I had the hoarseness of the voice. Initially, there was no problem with the breathing, but I now find that
strangulated kind of voice.
I have to.
So either we do the surgery and open the vocal folds up, but then there's a permanently breathy voice, or we give, you know what botulinum toxin is, Botox, right? So that's a poison which works in our favor because it causes paresis of the vocal fold. So we inject it into the thyroarytenoid muscle. So therefore there will be a little bit of a gap, and this is what the patient will sound like 1 week after the injection.
Start now. My name is G.S. In fact, I had some voice problem, strained voice, and actually, I used to have a lot of
spasms have gone away.
Now, also was given, and it was given last week or 13.
Last only 6 months. Botox last 6 months.
Found that there are no spasms.
We have Botox clinics where the patient will come back every 6 months too. We'll have patients coming from all over India, patients coming from Kenya and Dubai every 6 months for their injection, because you can't just give the injection, you have to do it with laryngeal EMG control. You have to know that you're in the correct muscle, so that needle has to be hooked onto an EMG machine. And then I showed you a situation where I made a glottic web to raise the pitch, but you can be born unfortunately with a glottic web. Like this individual, you are not seeing vocal folds. You're just seeing a sheet in front of you. So that's a huge glottic web. We take a laser and we just cut the glottic web to open it up. Very easy to do. But if you just cut it and don't put a stent, then it will re-web. So we put a stent in through the mouth and we keep that silastic keel there for about maybe 3 weeks or 4 weeks, so that the new skin can grow over there, and then you have to take the keel out. So here the problem is opposite, where there is a web and the pitch is high pitch, so the boy doesn't want that pitch, so you cut the web, and this is what the keel looks like endoscopically. This is how the patient sounds before surgery.
From Karnataka, and I'm studying in engineering final year. And since I have this problem from my childhood, I also think my voice is quite feminine in nature, and I feel much difficult in the crowd.
Now he wants a job, so he wants his voice improved. Now this is in 2 years after surgery.
My name is Nupur. I am from Karnataka. I have gone through that operation 2 years ago, and now new people won't even recognize the problem which I had earlier. And these days I feel very good.
And then you can also be born with depressions in your vocal fold. Like you have potholes on the road, you can have a pothole on your vocal fold, unfortunately. And when that happens, the voice can be again high-pitched and very, very hoarse. And these are surgeries which are difficult to do, because it's very easy to take out a polyp or take out a cyst or even take out a cancer. But to create a layer which is not there. Now, do you know what the layers of the vocal fold are? We have the skin, then we have a jelly known as superficial lamina propria, then we have a ligament, and then we have the muscle. This is the vocalist muscle, thyroid muscle. So if you have an absence of that jelly SLP or ligament, then you get these kind of potholes, like linear potholes, which you see in this patient. This is the right and left vocal fold. Right vocal fold, left vocal fold. And you're seeing this big depression here, right? So very difficult to create a layer. But what is the option we have? We can make an incision like you see I'm doing right now. We can elevate the skin. We can take the fat of the patient, make it into small pieces, and we can fill up this pocket with the fat. Then we can suture the edges so that the fat doesn't pop out as soon as the anesthesia is over. So it's a very cumbersome kind of surgery. They're very technically not easy to do. And at the end of it, the improvement in the voice would be between 20 to 50%. Not a dramatic improvement, and you should not promise that to the patient. So some conditions are more difficult to treat than others. In fact, cancer is not so difficult to treat when it is stage 1 and stage 2. Because we have now lasers which are really state of the art. This is what a laser looks like with an articulated arm connected to a microscope. And this is the patient with the scope in the mouth. And the laser beam will go through the scope. It looks like a red dot or a red line. And we use these lasers because they're very effective cutting tools which control bleeding. So it's called like a hemostatic scalpel. So if you have a malignancy which is T1 or T2, early stage 1, stage 2, like here you see there's a malignancy of the left vocal fold here. So we remove it with the laser. And then you see the stroboscopy of the patient is pretty good. You cannot really tell which vocal fold was operated on. All that depends on how deep is the malignancy. If it's going very deep, then you would not get such a beautiful mucosal vein. Patient is admitted in hospital only 1 day, and this is what the voice is.
मेरे कैंसर का ऑपरेशन हुआ था 1 से 1 तारीख
maybe 1 month or 2
अभी
months later.
होने में बहुत तकलीफ था अभी ऑपरेशन होने के बाद मेरे को अच्छा था आवाज बस.
These are phonosurgical principles for even treating malignancy. But sometimes you have stage 3 and 4, and then unfortunately the whole voice box may come out if chemoradiation therapy is not an option. Then what do you do for the voice? Can anyone tell me what will you do for the voice if the voice box is out? So we have 3 options. One is electronic larynx, which you just causing the resonators, the pharynx to vibrate. Very robotic kind of a voice is created. Second is to use your air in your stomach and esophagus and cause a burping, belching and the vibration creating a sound, what is known as a esophageal speech. And finally you have the TEPs or the tracheo-esophageal prosthesis, which you put in between the trachea and esophagus, and they have a valve, so you block it and the patient is able to talk. They're very expensive, about 37,000, and we have a very dynamic individual, a Dr.M.V.L.K, who's now making them for about 50 rupees. I think it is still to be patented, but I mean that is a remarkable achievement. And we've had 2 laryngeal transplants in the world in America. Why so few? Because you're giving immunomodulators, steroids, everything for an organ which is not vital at the end of the day, because you can have a tracheostomy and the patient can survive. And at the end of it, both these patients have a tracheostomy still because the vocal folds are not opening and closing. So as things advance and that gets better, maybe laryngeal transplants would also increase in the world. But everything goes back to the cadaver lab, and that's how I'm going to end my talk. And listen to this. Can you tell me what is the musical instrument you're hearing? Should I take questions? Yes? Are there any questions? Don't feel shy, you can ask anything. How many of you would like to become laryngologists? think Ketan, there are no questions.
Thank you very much for the excellent talk. I'm sure all of you must have enjoyed. I came in a little late, so I would like Neelam to welcome Nupur with a flower. I don't know whether somebody introduced you to her or not, but one of the times in 1985, she was one of the students sitting like all of you, and you can see where she has reached. When she left teaching institute, it was very unfortunate day. I told her we have lost a good teacher. She resigned on 5th September when she was associate professor at Science. I hope she remembers, but I remember it very distinctly. She passed like all of you from here. She did postgraduate at KEM, then she was associate professor at Science, and now she's a consultant at Bombay Hospital. She started her journey getting into the laryngology way back in 2003, 2002, when she went and trained herself at Vanderbilt. Then she went to Mount Sinai at New York and at Harvard, and then she decided to only concentrate into laryngology. She can afford to do that because her better half takes care of the rest of the patients. And you can see that now she has been a very active member in the Association of Phonosurgeons. She's been an ex-president. She's been training many students. She has a fellowship under her. She's probably trained over 17 fellows under her. And she's fully concentrating into voice and voice modulation, early diagnosis of cancer, and everything which is pertaining to laryngology. Whether it is a neuromuscular disorder or vocal abuse, and you saw all her examples. She has many publications in national and international journals. She has moved all over the world to share her knowledge with everybody, and I'm sure it was a very good decision by the chair to give her this opportunity and stimulate all of you to be a part of this. I would like Lupa Madam to felicitate her with a small moment, and I'm sure she's going to cherish that.
It's love.
It is written proud GSMC alumnus.
Thank you.
Thank you very much. I have one more suggestion. On Friday, 4 o'clock, you will have another exposure. If you will come, I've been always telling that people say that you can take horse to water, but then how to make them drink. Whereas I am facing another difficulty. There is excellent water, but I don't know how to bring horses to that water. But anyway, at 4 o'clock on Friday, medicine in art. Various paintings where how the painters have projected medicine. If you spare your time, then as they say, water is really delicious. So it's only you that I can't make any other efforts except telling you that, I don't know, even downstairs Dr. Kapur-Nerurkar made a point about humility and humanity. Here Nupur also made that point that ultimately, if you want to be a doctor, isi ka naam has that kind of label, then this undersurface of your IQ to be matched by EQ and SQ, all this we are trying our best to give you this exposure. that express and enjoy yourself as a complete human being who is meeting another human being in distress. Thank you.